So it's great to introduce Professor Bob Veselis from Sloan Kettering.
Memorial Sloan Kettering.
Memorial Sloan Kettering Hospital in New York City. I'm Professor Mike Wang from the University of Leicester, United Kingdom. So the first question I wanted to ask you about was, what is your definition of an adequate general anaesthetic?
In terms of an adequate general anesthetic, I think probably the most important component is that of amnesia. I think most people undergoing anesthetic or most procedures, their preference is not to quote unquote remember a thing during the procedure. So I think amnesia is probably the most important component of an anesthetic. Explain my rationale for that. Anesthesia is comprised of multiple components, as you know: treatment of pain, analgesia, unconsciousness, hypnosis, amnesia, memory, and lack of movement, where the people use neuromuscular blocking agents, or as more popularly called, muscle relaxants, as a means to prevent movement. Now, the unfortunate part of anesthesia is that we really have no objective measures of all these different components. What we do have is clinical experience and our best guess as to what would be the best doses of anesthesia to use for each particular component, based on our clinical experience and various studies and so on. The problem is it's not 100%. And if there's some mishap with one of the components, in other words, not enough pain medication, not enough hypnosis, probably the best safeguard for a satisfactory anesthetic would be to have amnesia. So that's why I say amnesia is the most important component, I think, of the anesthetic experience.
Do you have any problem with the circumstance of a patient in pain and distress during an operation, during a procedure, but then subsequently to be amnesic?
Well, that's if the patient, for whatever reason, is in that situation, I would certainly want them to be amnesic for it, because I think the evidence shows that if you're not amnesic for it, that type of experience is very traumatic. However, if you have that situation and the patient doesn't remember, the degree of trauma is much less. I'm not sure that people have really demonstrated that there's significant negative outcomes in that situation. Now, obviously, you want to avoid getting into that situation. So that's why I say, anesthesia is multiple components, and you have to give medications to treat each component. Now, what we tend to do is we tend to give large doses of medication for each component, and I'll use pain as an example. With the advent of remifentanil, which is an extremely potent analgesic, we can massively overdose, in the sense, the medication to treat pain as it's happening, but it wears off very quickly, and it has a high safety index. In other words, you can give a very large dose and not much negative happens in the setting of the anesthetic theater. In general, what we do in clinical practice is to sort of tend to give more medication than may be necessary, because at the time we're not 100% sure whether we're targeting the effect that we want.
Yeah. Okay. I don't want to put words in your mouth, but let me just try and summarize what you're saying, so that I'm kind of to clarify that I've fully understood what you're saying. So it seems to me that you're saying that the most important thing is that the patient doesn't remember after it's happened. The fact that some patients might be in an extremely unhappy, that's a British understatement, unhappy state intraoperatively, and possibly in very severe pain, is from your perspective, unfortunate and probably undesirable, but it's not the main point of a general anaesthetic. From your point of view, the main point of a general anaesthetic is amnesia post-operatively. Is that correct?
I'm not 100% correct.
Okay.
I agree with your statements about unfortunate, and you want to avoid those situations.
Yeah.
The amnesia, I think, is important in the sense of a safeguard.
Okay.
If the amnesia is present,
Yes.
that minimizes the negative consequences of such events.
But my starting question was, how would you define an adequate general anaesthetic? And you responded by saying the key thing is amnesia.
Right.
Are you still operating from that stance, or would you want to say for an adequate general anaesthetic you need to have a bit more than amnesia?
Well, I think, yes, you have to have all the components of the anesthetic experience, and they need to be balanced. But I think amnesia is the most important because it is sort of the backstop for negative consequences if the other components aren't quite right.
Would you have concerns if one of your trainees made it clear that they were targeting amnesia in terms of their titration of anesthetic agents, as opposed to any other variable?
I would encourage the trainee to be thinking of targeting amnesia, to always be thoughtful of that, but not at the exclusion of other components of the anesthetic. So you have to always think of all the other components: pain, hypnosis, and amnesia, and movement, muscle relaxant. Sure.
But I'm sure you can see what I'm getting at here.
Right.
What I think is a little bit ambiguous about your position is that it seems to me that you're almost saying that it's quite possible for a patient to be in a very unhappy state intraoperatively. That it's almost, although undesirable, it's almost like that might happen, and you might shrug your shoulders. But as long as they are amnesic after the fact, it's okay, it's acceptable. Is that right, or am I putting words in your mouth?
Well, I think it is more acceptable than if they do remember. So once again, I emphasize that the amnesia is an important backstop for mishaps.
Yeah.
Now, we know anesthesia is a very complex operation. I think in terms of awareness during anesthesia, people who have explicit recall of being awake and paralyzed during anesthesia, the thing I always like to emphasize with trainees and everyone else is it's important to be aware of awareness. I think a lot of people forget about that when things happen, multiple events are going on. Sort of the Swiss cheese model of events that people forget about that. And I think it's important to train people to be aware of awareness. In other words, to realize the patient has muscle relaxed on board when that is the case and that they need to be anesthetized, may not have adequate signs because the patient's not able to move. So I think being aware of awareness goes a long way to deal with the problem.
Okay. So what do you make of my position, which is that the definition of an adequate anesthetic is one in which there is oblivion, complete and reliable intraoperative oblivion, irrespective of amnesia post-operatively. And in fact, I would go further to state that it seems to me unethical to target amnesia if you know that a proportion of patients are going to experience distress and pain intraoperatively, but that it won't matter somehow because afterwards they'll have no memory of it.
Well, I think targeting oblivion may seem like a good thing. That would I think in general require larger doses of anesthetics. And there is some evidence that's still being worked out. Larger doses of anesthetics may be harmful in certain patient populations, in older patients, patients with some frailty before their surgery. We're getting many more older patients undergoing surgery, where we have an increase in this population. Now, oblivion is, I think, connotes a very deep level of anesthesia. You may not necessarily need that for most patients.
Yeah. But I might argue that if you don't operate on that basis, you are inevitably going to have a percentage of patients who are conscious intraoperatively, maybe without explicit recall, but nevertheless conscious intraoperatively, possibly in distress and possibly in pain. And the argument I would put to you is that if that is the target of, as opposed to amnesia, then it seems to me that's a much more ethical stance. And in relation to your point about overdosing, I think we heard yesterday that there is still little or no real hard evidence that overdosing is causing neurotoxicity.
Well, I agree that is still a question open to debate. I think also there's really little or no evidence that unrecalled consciousness or awareness during anesthesia, though I don't like the term consciousness, I much prefer the term responsiveness, that is not recalled. Also, there's really lack of evidence of any negative outcome in that situation as well. So you have two opposing sorts of parts of the scale. And I think many of the cases of awareness where you're awake and paralyzed are related to systems problems. People running out of anesthetic agent and vaporizer, people not being aware of awareness, people not being aware of muscle relaxant being on board, and so on. So I think those systems problems are just as important to address as the issue of oblivion.
Okay, so let's cut to the chase, as they say. So if you or a member of your family needed to have surgery under general anesthetic, and you had a choice of two anesthetists, one of whom would always target amnesia and one of whom would always target oblivion, which one would you choose?
I would choose the, well, when you mention oblivion, that includes amnesia as well.
It does.
Right. So I would choose a person who is aware of the importance of amnesia. I would not choose an anesthetist who feels amnesia in the absence of any other modality is sufficient anesthesia.
Okay. So you would actually go for the oblivion targeting anesthesiologist?
Well, I would like to have somebody who is aware of the balancing act of anesthesia between oblivion and awake recall, and that I wouldn't want somebody who's just going to be giving more anesthetic drug because they're not sure of what is happening with the patient, regardless of other information. Once again, the whole issue of whether there was a level of anesthesia that was harmful postoperatively in terms of cognitive function arose from the fact of using a depth of anesthesia monitor in terms of trying to target a middle range of anesthesia. And as it turns out in the data analysis, they found that patients at a deeper level of anesthesia had significantly higher morbidity afterwards, and that started the whole
Yeah, but there's only
conversation.
been one study that's shown that. And the other point that I would make to you is that there have been these nice studies where there's been a comparison between regional anaesthesia and general anaesthesia with matched problems, surgical procedures and so on, and there's actually been no difference in POD, post-operative cognitive deficit rates in the two groups.
Right. Well, but I would a bit disagree with the that there's only been one study in terms of the deep anesthesia. There's been multiple studies that go back and forth, and currently underway there's a large study looking at whether...
Yeah, we keep hearing about it, we never see any results, do we?
Well, it should be in the next year or so. It's a very large study, but I think it hopefully will be definitive and help answer some of these questions. For instance, if that study shows that there's no difference in the two outcomes, then I would be certainly more in favor of oblivion. But until then, I think one has to be cautious in making dogmatic statements. And until then, I think